Welcome, everybody. I'll just wait for a few more people to enter in. I think we're ready to go. Okay, so good evening, everybody. Thanks so much for coming along tonight. My name is Katie Garrett. I'm a program coordinator for the Gold Coast Primary Health Network and work in our aged care and palliative care space. So I just wanted to firstly thank you to everyone for attending tonight. For this webinar, with deep appreciation for just how busy you all are in general practice. So first off, I'd like to start by acknowledging and paying respect to the land and the traditional practices of the families of the Yagamba language region of Southeast Queensland and their elders past, present and emerging. So for tonight, we were wanting to share some exciting work that we're doing in the early intervention space to support healthy ageing. So a little bit of background to how we've gotten here is in response to the Royal Commission, there was a commitment of 17.7 billion committed to an aged care reform package. And with that package, it included specific funding for primary health networks, which provides a really significant opportunity for PHNs to deliver a coordinated response to address many of the issues faced by the aged care sector, but also an opportunity for us to enhance integration between health and aged care services within the region. So as part of this, Gold Coast PHN has received funding to specifically support early intervention initiatives that contribute to healthy ageing and support senior Australians to live in the community for longer. The Royal Commission found that there was a considerable portion of older Australians that were entering aged care facilities earlier than they may otherwise, largely due to a lack of support for healthy ageing or their inability to be able to manage their chronic conditions in the community. So our PHN have undertaken a range of activities in this space, including working with primary care with a focus on patients who are frail or at risk of, and also funding to commission several healthy ageing programs, which you will hear more about tonight. So before I hand over, just a few friendly housekeeping reminders. I think we're all pretty aware of them, thanks for the last few years. But please just keep your cameras off and microphones muted unless you're invited to participate. Questions, you feel free to use the chat feature at any time. And then the event tonight is being recorded and it will be available via our website in the next few days. So from here, I'd just like to make a few introductions. I'd like to extend a really warm welcome to the guest speakers that have given up their time tonight, starting with Dr. Chris Boland, who many of you will be aware of his work in general practice from BMP Healthcare Consulting. We also have Joyce McSwan online, who you may also be aware of running our persistent pain program in the community, but she's here tonight to talk about her new frailty care in the community program. We also have Professor Susan Brandis from Bond University's new Bunya, I hope I said that right, Healthy Lifestyle program, and Amy Tooley from Gold Coast Health to talk a little bit more about the Better Cardiac program and Gold Coast Health's Mungali Clinic. So from here, I would love to hand over to Dr. Chris Boland, and I will stop sharing. And Chris, I think you're on mute.
Right, I'll unmute and I'll put my screen up. There we go. And just get us onto the right area. It was smooth sometimes. Right, here we go. Now, so thank you very much for that introduction, Katie. And so many of you on the call tonight have, we've worked together either face-to-face workshops or we've been doing some virtual catch-ups in the Doing What Matters frailty identification and keeping older people well at home program. And so what I'm going to do, I'm not the main act tonight. It's fantastic speakers, Joyce, Susan and Amy, that will be helping you work through what's available. But I'm just going to give those of you that haven't been involved in the program so far just a little bit of information about why bother about frailty. So why this program and why this program now? So one of the really big things that we're all aware of in the last 5 years, there's been a 30% increase in people over 65. That's a good thing. We're all living longer. And but the aim is, are we living healthier into our older age? And that's the really big sort of question, is that we all want to live younger, longer. So we've got to actually do something about this. And there's more of us than ever. And by the way, the Gold Coast is a very lucky area that you've got over the national average of people over 65 loving the lifestyle on the coast. And the Gold Coast North, 24% of the Gold Coast North region is over 65. And lots of men aged 70 to 74, which is really good because it means that men are surviving longer. They may well be doing better with their overall health. But this next part of the life, from 65 to 105, we've got to think about, is it a healthy journey? Is there a good quality? As a GP working regularly with older people, this made me think a lot about what's the impact at a practice level. This group of people have got multi-morbidity. They come to see us a lot more often. Many of you will probably think that half of your practice are over 65, but it's not that. It's just that they come more frequently than anyone else. The average 85-year-old comes around about 15 to 17 times a year to the practice. So there's plenty of opportunities to actually review what's happening with them. One of the other elements of why we need to be here is this group is aging well, but one of the biggest issues, according to Ruth Hubbard, who she's a geriatrician from University of Queensland that I've worked with in the past. And this is a quote from her that she says, frailty is the most significant challenge to all of us aging well in the community. And more than 20% of people over 65 will be frail as they age. So I want you to think about that in your practices. 20% of your people over 65 will be frail. And the majority of you are not actually started coding or putting frailty as a long-term condition in your medical director or best practice software. It is something you can actually do now. We'll talk a bit about that in a moment. Why else do we need to be here? 50% of our older people over 75 are 8 or more medications, so a big medication burden. And this group has a very high prevalence of chronic kidney disease. 40% will have an EGFR less than 60 mils a minute. And that's pretty important to recognise when a large number of people are on renally clear drugs or are being prescribed drugs that are renal toxic. So that nephrotoxicity and renal clearance issues mean this is the #1 patient safety issue in primary care today in Australia. And we need to be much better at coding for chronic kidney disease in our software. Otherwise, we won't pick up the drug interactions. The other big issue about having lots of older people in our community is that this multi-morbidity has meant that there are lots of specialists out there. So multiple prescribers with a single disease, single organ, who are often unaware or maybe not even interested about the interactions of their particular medication and the rest of the person. So in the end, it's GPs and geriatricians who need to be thinking about deprescribing. We need a lot of assistance from our colleagues, the pharmacists, to do this as a team approach. And find out more from Joyce as well on that. So in the work that BMP Healthcare Consulting has done on the Gold Coast over this year, many of you who have interacted with me have told me about the barriers to recognising frailty. #1, of course, is time. You don't have enough time, but remember, they're in your practice pretty regularly. But the big issues apart from time are that there's a lack of knowledge of referral options in our area. They just don't exist. That you also mentioned that many of you actually don't know the referral options that actually did exist for older people who are living with frailty. Our patients are often not wanting to pay extra money to see service providers. And you're very aware that many older people use all of their Medicare funded visits for podiatry, and there's nothing left over for the other allied health that have a big part to play in helping change the trajectory of frailty. And of course, My Aged Care is also an option, but their referrals take a long time. And you've told me that the GP is often not kept in the loop about how long it's taking or even when service providers get involved. So these are big barriers to embracing frailty as a concept, because you need a lot more knowledge. So I'd like to introduce Mrs. Andrews to you tonight. Many of you may have seen this little video, but she's the character that who is frail, and she's one of the 20% in our practice that we need to be looking at recognising earlier.
My name is June Andrews. I'm 84. This is the story of my trip to hospital. It started one Friday evening when I had a fall in the bathroom. My husband called the out-of-hours doctor, who told us to call 999. Arthur couldn't help me get back up on my feet. I had a nasty bruise over my right hip. I wasn't keen on coming into hospital, but they persuaded me.
I was on call when Mrs. Andrews was brought in, and I arranged a hip X-ray. There was no fracture, but some blood and urine tests showed that she was a little dehydrated and had a possible water infection.
Mrs. Andrews was moved on to the acute medical unit. She was getting close to breaching the 4-hour target. It was also getting late, and the AMU was a safer place to assess her and get her back on her feet. We put up a drip and gave her some antibiotic tablets for the urine infection. On Saturday morning, she was seen by the on-call medical consultant. Before we could look at her mobility, the patient flow team insisted we move her to the first available medical bed. She was not reviewed again medically till Monday. There is no routine physiotherapy or occupational therapy over weekends, so we couldn't refer her to the home rehabilitation team before then. By Monday, June had been on either a trolley or in a bed with the cot sides up for 3 nights because she was deemed to be at high risk of falls, and the nurses had inserted a urinary catheter. She was seen that Monday morning by the physiotherapist, who got her out of bed with the aid of a Zimmer frame. My home ward is in the elderly care unit. We do our best to provide a regular liaison service to other wards, although we wish the doctors there had more knowledge about managing older patients. The ward doctors and occupational therapists made a plan to get some more information about June's usual abilities and past medical history.
I'm June's husband. On Monday, I was able to get back into the hospital to see her on the ward. I told the ward doctors and nurses that June had been getting more unsteady recently, had suffered another fall, and that her memory isn't what it used to be.
The review team discovered that her blood pressure was dropping very low when she stood up, postural hypertension. It often leads to falls and faints in older people. We stopped a couple of her cardiac medications to try and solve this problem. By Wednesday, she was able to stand with assistance. The physios came to see her, and a plan was made to refer her for ongoing rehabilitation in the local community hospital before going home. But not for the first time. There were no community beds, and by the 10th day of June's admission, the cardiology ward desperately needed beds for acute cardiac patients, and she was moved to a winter escalation ward. After all those moves, Mrs. Andrews had become confused and agitated. She had another fall, sprained her wrist, and now she required 2 nurses to transfer her from bed. June spent increasing time in bed with the cot sides up. By day 12 of her admission, the community hospital phoned back saying that she had no rehab potential and should have a care package instead. She was referred to social services with a target discharge date for Friday, but the package couldn't be put in place till the following Tuesday. She went home with a 3 times a day care package, but with no clear diagnosis for her progressive memory impairment and falls. 7 weeks after her discharge from hospital, June had fallen twice more. Her memory was worsening, and Arthur was becoming stressed, concerned, and exhausted. June ended up being admitted for respite to a local care home. Mrs. Andrews never got back to her own home after her respite. We should have more care and support for older people like her outside hospital, and those services need to respond much earlier to people's needs. But the way we treated her in hospital and our difficulty getting her back on her feet and home again didn't help. With so many frail older people coming into hospital, we have to get this stuff right for everyone.
So really,
My name is
tonight we're looking at Mrs. Andrews as a character, and really we think, what could we be doing differently earlier for Mrs. Andrews to actually keep her from that trajectory of decline? All of us over 40 are losing muscle, and then after 65 we lose it even more quickly. So we need to be thinking about recognising Mrs. Andrews at an earlier stage. So let's just have a think about what frailty is. It's a multi-system impairment associated with this increased vulnerability to little stressors, such as a UTI that Mrs. Andrews had, a COVID vaccination, a medication change, a little inertia. So these little things that are, I call them road bumps for the more robust person that's aging healthily. If you're frail, it's a big drop in your resilience. And so it's recognized by having at least three of the five, weight loss that is actually unintentional. And you saw Mrs. Andrews was a big lady. She may not have noticed much weight loss, but things like weak grip strength, feeling more tired and exhausted, not being very physically active and walking slowly. These are the key features. And so Linda Fried, who is a geriatrician from Canada in 2001, described this, and it's now accepted worldwide that that's what we need to be looking for to actually recognise frailty. And 3 or more of those symptoms are what we need to actually say, right, Mrs. Andrews is likely to be frail. And she scores 3 out of those 5 at least. And it all relates to this loss of muscle mass that occurs after the age of 40. So many of you have seen this slide before. We need to think, can we do something differently 2 years before this video, or even earlier, when people are feeling they're slowing down? And we could have a new conversation with our older people by recognizing that it's never too late to build muscle for them. The evidence is that if people are mildly frail, it can be reversed. Moderately frail, it can be stabilized to prevent further deterioration. And these are clear guidelines from the Asia Pacific guidelines, which were brought into Australia in 2017. And there, the guidelines are on the screen there, that essentially we need to be using validated measurement tool to identify frailty. It's really interesting. The Silver Book from the College of General Practice, which has put out 4 or 5 editions. The last edition 3 years ago actually started talking about frailty for the first time. So if you want to know a lot more about frailty from the RACGP perspective, have a look at the online Silver Book. There's a great section on frailty and undernutrition. So we really need to think about an older person living with frailty as a long-term condition, rather than this chaotic episodic care that Mrs. Andrews went through. And we can do it in our practices by identifying it early, just like we would diabetes, and putting in proactive care that where we can actually support Mrs. Andrews to understand what she needs to do to help improve her lifestyle and what her choices are, with planning her wellness for the next 12 months and getting her to think about what her real goals are. And we need to be doing it in our practices, not in a hospital setting. So you've all seen the frail scale, so I won't go into too much detail, but those of you that have not seen this, it's simply John Morley's frail scale, that if people score 3 out of 5 or more, they are frail and would benefit from physical activity, a medication review, addressing their causes for their fatigue, looking at increasing their protein, and definitely putting them on vitamin D because it has a benefit for their muscle health. So really, if you want to make a difference in the care of people, I ask you to think about this 20% of people that are in your practice that have frailty. Let's identify it and let's do something about it. In the next couple of days, you'll see that there are some referral options from our providers that we're going to talk about in a moment. It'll be on the Gold Coast Primary Health Network's Older Persons webpage, and you'll find information about their offerings there. But that's enough from me. And Katie, I'd like to hand over to the speakers. And I think Susan is speaking next, or no, sorry, Joyce is our next speaker.
Wonderful. Okay, let me just share my, oops. Hang on, sorry. Okay. Perfect. Okay. Thank you so much for having me, and great introduction, Chris. It's a delight to be able to present something different with the PHN. So we've been, some of you might know myself or talk to us or referred to us, but PainWise is my organisation, and we've been working with the Gold Coast Primary Healthcare Network since, well, it's been 10 years we've just clocked, which is quite amazing. So we're quite aware of you know, how to run primary care programs, how to report on them, how to collaborate with the greater primary healthcare unit. So it's been awesome to be, you know, kind of requested to actually look at developing something for frailty care in the community. Interestingly, even in the persistent pain space, we have a lot of patients who actually sometimes come across this this issue as well. And by virtue of managing their pain, we sometimes communicate that back to our doctors. So it's not a space that's too different in some ways to what we already know. That said, it also has its own very unique set of identifications. So here we are. So let me tonight, in the short time that I've got, just tell you quickly a bit about ourselves if you don't know us, and then also more importantly about the program. So as said, been working with PHNs for our last 10 years, and we've actually had models of care also elsewhere in Australia. We work on an interesting mixed funding models, which has been recognised by the Productivity Commission to be a very healthy and economically healthy, innovative way of working, so that, you know, they get the bang for their bucks in terms of investing into primary care. What's important is that we are very focused on a whole person centered care approach and collaborating and supporting primary healthcare, both the allied health and our medical stakeholders. And really, my hat's off to primary care always, our GPs, our allied health, who have to be managing so many things, you know, from cough and cold sometimes right through to really complex care. So in terms of the cornerstones of the frailty care program, it's really important, I think, before we sort of launch into all the service offerings, just to highlight the value of where we're coming in from in a program like this. So it is highly compassion based, because this group of people really require, you know, a lot of patience, and perhaps even some repetition, because we're not going to get them in a very well state, which is why we're here. So it's strongly based on compassion, very much whole person approach, so that we are looking after the different facets that I'll show you in terms of what is a poor trajectory to their progression if we don't manage it early. It is very much function based rather than disease focused, because I think, you know, it's without saying that they have many comorbidities, but it's very easy to focus on that disease and turning it into a KPI and the measure. And while we have to do all that, we also must be mindful, which this program will be, in terms of how, what matters to them, you know, what does it mean to them to be functional? Is it our definition? What's their definition of function? So goal setting, even in that, you know, small steps approach in the early days, is really empowering and important, because I can only imagine, and from actually before pain, I did many years ago, I think before 20 years I've been in pain world, but before then I was in aged care consulting in the regional areas. So it's almost going back a full circle. And it was very important to understand what it means to them to be independent. So collaborating with partnerships, the model is based on collaboration, based on our pain model as well. And of course, evidence-based, and so important to use the right current evidence and also the right tools for monitoring and assessing and identifying. So pathway of the program will look a lot like this if you follow through with me. Step one, is going to be a referral process to remain consistent with everything that Dr. Boland has been working on this project with the primary health stakeholders here. We'll be remaining consistent to the FRAIL scale, which is a very easy to use scale, and it's a really good initial awareness identification scale. Within our program itself, this is for the referrers, within the program itself, we will be using other scales like Edmonton, just for our own internal monitoring, reporting. So we'll be using some of those other validated scales. But to keep things simple, on the website that Dr. Boland showed before, where we've got the GP referral and where you'll, be able to get some information sheets, well, that's where you'll see the referral form. So it must be GP signed off for this program, and I'll go through the eligibility criteria shortly. However, the allied health, if there's allied health on the chat tonight, on the program tonight, allied health can co-refer, because sometimes you're going to be the ones that's picking up on this, frailty. So especially physios, exercise physiologists, even dietitians, you will be seeing some of these patients. So feel free to remind the GPs and then send the form with the patient or send it directly to the GP. And then that way the GP can get a sign off. If for any reason the forms come into us and they're not signed by the GP, that's okay, as long as we know who the patient is, of course, and we can follow that up. But for our process and to alleviate some workload for us, it would be wonderful if the GP can sign off. That said, that GP sign-off is really, really important, because we want to participate not independent of the medical staff, especially for this cohort of patients. And we do find from our previous works in pain that patients do tend to comply more when they know that GPs have authorised and approved it, which is very good. So then what happens is they'll come in to our triage, and we'll conduct an assessment. So that'll tell us whether they're low, moderate, or high risk, and then what we provide from there. So depending on the risk classification, they will get one of these three things, and they're not exclusively you get this or you don't get this. We will see where the patient's at, we'll see their priorities, we'll see what their capabilities are, and certainly provide as many of these first four things are really important. So medication review, as Dr. Boland said before about the prevalence of medication misadventure, medication non-compliance, that's really important. So we will have both in-service medication review and home medications review as well, so that the patients can go to the doctor's home. Now, for a GP, the home medicines review, you'll be quite familiar with that. And from a Medicare perspective, you'll be able to claim on that as well. So we may be asking an additional referral for that to our collaborating pharmacists. So we will have specifically specific collaborations with some HMR pharmacists who will be aware of how this program works. Separate to that, we will also be looking at providing progressive resistance training. Now, as we know, that's really important for building muscle mass. So again, we will have to structure what that program looks like, whether it's a one-on-one initially or whether it's group-based. And then, of course, a nutrition review as well. Now, as I said, some of these things can happen in individual because it's a very personalised program. So we won't be putting everybody into such a group if they're not ready for group. They do also have in parallel the options to go to group-based self-management frailty programs, which we will conduct. Now, they will usually be kind of in with a movement group program as well. So while they're moving, they're also learning and they're also socializing, because isolation is certainly a huge risk factor, as we know, for frailty. They'll make friends, so having that support collegially with each other, as well as from the clinicians as well. We hope from there that from there, there's the potential to also grow peer-to-peer support group that will be sort of overseen by the clinical team, but by and large, something that the elderly can actually, foster themselves as they're getting well. So depending on the risk categorization as well, some of them will need home-based services. So there is funding for mobile physios and as I said, the home medications review, and also any check-in service. Now, this is not for everybody, but this is definitely for the high-risk folk, and their risk might reduce as they get well. So that may change, and we'll review them along the way as well. We will also be able to, aside from going to their home, the model also allows us to refer them to our existing contracted multidisciplinary team, which consists of dietitians, physiotherapists, and to a certain degree, psychologists. With the psychologist part, though, that will be on a mental health care plan. So while we have team members whom we collaborate with, the funding doesn't fund for psychological services, individual ones. We will ask the prescriber to be referring the GP to referring under a mental health care plan. And the patient might already have some of these team members on board, in which case we don't want to duplicate those. So that assessment's really important, and then drawing up that individual plan is really important. And not forgetting that we will be communicating all of these back to the GP as well, and including any other allied health team members. That's what we currently do now anyway with the persistent pain program. It's going to be following that very similar flow. So we hope, all things going well, that the patient will be with us for somewhere between 4 to 6 months. Now, it's the start. So we hope after that's why our peer-to-peer support group might be really useful, because that we can keep a distant eye then on them on that and see how they're going. And of course, we'll be measuring, the results pre and post. On discharge, of course, we will be providing some feedback to the doctors, let them know where things are at. And then we hope that they'll also continue with their peer-to-peer support afterwards. So, as I said, the 4 key objectives are resistance training, nutrition, medication management, mental health awareness, and support tools as well. So that's done, as I said, on an individual basis as well as in a group-based basis. It's based on risk categorization, so that, what the right program for the right person and for the right time. So it's not to say they need to do everything. We'll prioritize and see what's right for them for that 4 to 6 months. And again, what do they want? What matters to them? So I think that's on a compassion-based, whole person-centered approach. It's very focused on respecting what people would like to do within the framework of our navigation as well. So all the materials and the write-ups and our, whether it's course material or simple brochures, that's all available, and it's prepared, ready to go. Of course, we're focusing on that psychosocial needs assessment as well, looking at where they're at there, doing the multidisciplinary service, wraparound service as needed. So we're not going to overwhelm. This is all prioritized and agreed with the patient on it. And then, of course, as I said, feedback to the team. Our form is here. Now, if you're not familiar with the form, or you prefer not to complete the frailty form in this way, we have also built a Frail Scale online tool that's a very simple calculator. So it's just an electronic version of this paper version, whatever you prefer. It's there and easy to go, so you can calculate your scores, and the referral form is up there now. But those who are familiar with the persistent pain program will be familiar with this kind of form, one pager, although this time we had to stretch it over 2 pages for the scale, and then you can auto-populate. And I believe online there is the auto-populate version that, like the RTF version, that you can put into your software as well. So thanks to the PHM for helping us there. That is the where you sign off, the GP signing off as a final sign off, and then the allied health can also sign off there as well as a co-referral. Now, eligibility criteria wise, you've got your residents living in the Gold Coast, obviously, you know, at risk of early entry into aged care or complete the frail scale so that you know what that looks like. Now, those who are at risk of frailty, who are unable to access mainstream services, so where they don't have private health services already coming to them, or in a private hospital program. I don't know of too many doing frailty programs, to be honest, but if they're already in some kind of care to do with private health, then they won't be able to come to the program for now. Indigenous, however, this is, sorry, what is it? This may include but not limited to, right? So of course, all these folk very welcomed, ages 65 plus, older persons, and then Indigenous and Torres Strait Islander 55 plus as well. Okay. Now the exclusions are, you must not be under palliative care services, because that's not what we are in the scope of doing, and of course not living in a residential aged care facility as well. That won't be eligible. Okay, so to match it up with the frail, this is my final slide with a couple of minutes spare. To match it up with the frail scale, Dr. Boland very nicely kind of suggested that we match it up with the frail scale to stay consistent with that, and then to show you what sort of elements of the service will be offered that will help to manage some of these areas. So in the fatigue area, of course, we'll be looking at assessing for nutrition, medication, psychosocial needs. Of course, we will liaise with the GP about any cognitive assessments, or if you've already done MMSE scores, that we'll request that you will provide them to us so we don't duplicate. Or as we go along the way, if one hasn't been done, we might remind you that one should be done and to share that with us. Certainly referring to psychologists where there's loss and grief counselling required or mental health support, that would be, as I said, under the mental health care plan. But we can recommend certainly collaborating psychologists, and certainly where medications contribute to fatigue, drowsiness, typically dizziness, we'll be looking at through the lens of a home medicines review, and of course looking at polypharmacy. Now, the road of deprescribing is going to be something we will follow up and support GPs on. So it's not to say that we'll do the review and go highlight all these problems and then go, okay, over to you. Because a patient is with us for 4 to 6 months, it gives us a really good opportunity to try to support primary care in adjusting some of that deprescribing if required, or, you know, adjuncting, and that will include supplements as well, because a lot of patients will take supplements that may be unnecessary. Now, in terms of resistance, of course, we'll be looking at the risk factor of the patient, and then personalizing whether it's a more weekly intensive movement program they need, or a monthly, depending on what they already do and what they enjoy doing. So again, that function-based. Literacy on muscle health. So muscle health is so important. So looking at building on that from both an exercise-based approach, but also very much a mind-body-based approach as well, so that the body is comprehensive and we're not just focusing on, you know, leg and sit to stand muscles alone. That will maybe where it starts, but then we hope to help the patient to really be very body aware, self-aware, and move forward to really enjoy things that they do and claim that independence that they don't want to lose. Of course, as I said, with ambulation, recommendation of mobility aids to some extent, but that will be based on a physiotherapist or an exercise physiologist-based approach, not from an OT-based approach presently. And you'll hear from one of our other providers later that they'll have more of that covered. Literacy, again, on muscle health, and I repeat that about the mind-body approach. Illness, of course, I think the medication review part will look across that from their comorbidities as well, chronic disease. We will be following up with people on a fortnightly to monthly basis, depending on their risk. So those that are a bit more in the low risk, maybe more monthly, those are more high risk, they can be fortnightly, and they may be home-based visits, or they might be in person, or even a telehealth, or even a friendly phone call. So it'll be quite versatile to see what the patient can manage, but definitely checking in is important. We'll also look at some other chronic disease services that might support the patient as well, that either they're already doing or haven't followed up with, and so being mindful of other contributors to their chronic progression. And of course, where weight is concerned, there's no doubt the inclusion of dietitian who's already on our team, and the literacy on nutrition. And not just, I think that transacts as well on, oral health, looking at whether they're swallowing issues to do with the food. We don't have speech pathologists on team, but it may be very much looking at the functional approach to food. Mindful of sarcopenia as well. So while protein-based therapy from our foods is really important, certainly we'll be also looking potentially at amino acid therapy if required for supplementation, because in our high-risk patients, there is evidence to say that they will benefit from some of that supplementation. So we'll advise that along the way. And of course, excluding red flags. So I hope that provides a comprehensive overview of the service that we're very excited to jump on board with. I think that's almost all. So where will we be? Varsity Lakes is our main office. Group programs occur in Robina Community Centre. There is outdoor precincts there that we will use for some outdoor-based movement activities. We can go to the northern community centres in the Southport region, depending on demand, and of course, home-based. And as I said, in person at Varsity Lakes, or telehealth available, or picking up the phone as well. And we do also have after-hour support for them on the phone as well. If they need, they'll know our contact details. Right. I'm done. Thank you.
Thanks so much, Joyce. All right. I should have said at the beginning, there will be an opportunity to ask questions to any of our speakers towards the end of the session tonight. So next up, we have Professor Susan Brandis from Bond University.
Hello, everybody. Great to be here tonight. This is an incredibly important initiative. It's one that's very close to me. I'm an occupational therapist, and I'm head of the occupational therapy program here as part of the Faculty of Health Science and Medicine at Bond University. And I'd like to acknowledge Assistant Professor Neil Chapman, who's also online tonight, who's one of my partners here in developing what we've called the BUNYA program. BUNYA is Bond University Allied Health, and it's an interprofessional healthy lifestyles program. If we think about what our program is, it's a 12-week intensive active lifestyle program. So we're trying to use not the aging word, so it's about lifestyle, and it's linking with ongoing referral pathways that are aimed to sustain longer-term goals. It's been developed by Bond University allied health professionals, including occupational therapy, exercise science, physiotherapy, and nutrition and dietetics. They're the core originals, and we're considering in the future we'll be able to add psychology and potentially our medical students. It's designed to deliver bi-weekly client-centred health education and exercise classes to Gold Coast community members at a risk of frailty or of admission to aged care facilities. And as a university, it's informed by the latest evidence-based research. So we've had a number of our master's students do systematic literature reviews to make sure that what we've got in the program is the very latest. And it's positively framed around lifestyle redesign and behavioural change theory. So we're using that wellness model, which is around enabling independence, which is really, really core to my heart as an OT in terms of early intervention. So in terms of the program goals, and this aligns with the Frail tool, it's jumping around. We've got a 12, hang on, sorry, apologies. So improving physical function, the evidence shows us there was an RCT that showed that a 12-week progressive resistant training program improved muscle strength, physical performance and functional capacity in pre-frail older women. Number 2 is about decreasing risk of falls. It's a very good indicator of frailty and loss of independence. Kathy Sherrington found that exercise interventions that included balance and functional training reduced risk of falls in the community, including those who were pre-frail. The third goal is about improving quality of life. So showing that regular exercise has actually been shown to improve the quality of life in pre-frail older people. And again, some really strong evidence about that. So measuring quality of life outcomes such as physical function, mobility, particularly social participation and cognition. Reducing risk of hospitalisation, I think that's an incredibly important one. We saw that with the case study that Chris showed us with Mrs. Andrews. And number 5 is about improving cognitive function. So regular exercise, and there's a lot of research on this that links exercise to cognitive function, but also links exercise to mood and depression. And again, strong evidence around a 12-week program that combined exercise and cognitive training, improved cognitive function and physical performance in pre-frail older adults. So some of our other goals as a university, because we are a not-for-profit university, even though we are a private university, is about making a contribution to the community and very much focused on community development and what's called consumer co-design. So we've come up with a bespoke healthy ageing program to support Australians to live on the Gold Coast. And the input from the participants that come through our program, so it's structured as 3 rounds as a demonstration project. At the end of each program, we'll get feedback from the consumers that will inform the future program design. And that's incredibly important because of adherence and dropout rates in this population. Promoting healthy lifestyles and trying to increase access to health service participants on the Gold Coast. So what we're providing will be post-program referrals to appropriate local businesses, including over 50 gyms, other allied health for individual therapy, and potentially social connection groups. Again, there's research that shows where they did comparison between groups and individuals that the group programs demonstrated better outcomes, and part of that is around the social capacity that's built. From a university point of view, we're very keen to develop our workforce. We are currently developing the allied health and medical workforce for the future. So what the program offers is the opportunity for our students to do their clinical placements and rotate through the program. And what that does is complement external placement providers. But it's providing authentic clinical experience, because what we found over COVID was there was a great swing to do simulation training. We would much prefer to provide real services to real patients in need. And what it means in terms of our future workforce is that our students are master's levels in OT, physio, nutrition and dietetics. So they've already got a bachelor's degree in something else. And what we're hoping is that this program will increase the graduate awareness of what the workforce demands are in working in primary healthcare, as well as developing some skills to try and identify and manage those at risk in the future. A key component of our program is developing those referral pathways from GPs, but more importantly back. So developing those competencies in interprofessional communication, assessment skills, discharge and handover practices. And we all know that the adverse events happen because of poor discharge. And one of the activities the students will be doing is learning how to write a discharge summary back to allied health, and that will be back to GP, sorry, and that will be embedded in our curriculum. From a research perspective, we plan to provide a longer term approach to this. So because we have a very comprehensive assessment of the consumers on entry and exit too, we will be getting ethics and some consent processes in place so that we can start to store data. with the vision that we will be able to investigate some of the antecedents and effective interventions and the consequences of frailty in the Gold Coast community in a much longer longitudinal study. And that's a really exciting part that I was keen to share with you, because 12 weeks isn't long, but if we can build up a legacy here, we can really make a difference for moving forward. So what do the clients get? There's 2 sessions per week over 12 weeks. There's a 1-hour education group. The education group is focused on developing skills in health literacy. All of these programs are supervised by registered allied health professionals, so APRA or physio and OT, and dietetics and nutrition and ESA for the exercise science, pre and post clinical assessments. And what we're looking at is lifestyle changes that are sustained by referral to community continuing services as required. I guess our unique point of differentiation is that we are an interprofessional program, but also an intergenerational approach, in that the evidence shows that those intergenerational gaps with the older people working with younger students also has very positive benefits for both. Just to give you a bit of an idea of some of the education sessions that we'll be covering, we've got sessions What Matters to Me, and each client will set their own goals. There'll be education sessions around keeping active, strong bones, healthy eating, understanding balance, how to future-proof your home. You're in a nice home now. What do you need to do to make it environmentally safe? Technology and independence, hobbies and interests. We'll be offering a brain gym, transport and driving. One of the big things around frailty is transport and driving. That's a specific area of occupational therapy expertise. Meals, self-care, bowel and bladder health, sleep hygiene and sex, and home maintenance. So depending on what feedback we get from the clients, will shape some of those. We have already developed a number of these modules in our original pilot. So we've developed the packages on keeping active, strong bones, how to future-proof your home, and technology and independence, and got some really good feedback and suggestions from the clients for those. The exercise program is informed by the World Guidelines for Fall Prevention and Management of Older Adults, and the exercises will be developed to target the individual's capacity to maintain balance, with a particular link as to how do you do that during functional tasks that are needed for daily life, for your activities of daily living. And that's quite a unique partnership between OT and EP. And one of the reasons exercises fall off at home is that unless they're embedded into your daily routine, they just don't become habits. So that's when I talk about lifestyle redesign. And the exercises will be obviously based on assessment. They'll be individualised. There'll be both groups and as well as individual follow-up. 3 intrinsic risk factors: muscle weakness, balance deficits, and gait instabilities. And this has all been informed by our professors and our academic staff in the exercise science program here at Bond University. Let's go to the next slide. It's not liking me tonight. Here we go. So the service setting will be at Avanti. Here we go. For those of you that are in the Gold Coast near the Robina Stadium, you may have noticed that there's a big building going up between the Robina Sports Stadium and the Bond Institute of Health. So that's the extension for Allied Health, and we've got some fantastic new facilities, and that will be opening in September. Initially, we've partnered with Avanti Health Centre, so our groups will be run at the Gold Coast Surgery Centre, which is right opposite the tram station. For those that remember it, it's opposite where the old Gold Coast Hospital used to be. A lot of younger people have no idea where that is, so the Dendy Theatre. And then once we get rolling, there'll be opportunities for individual follow-up and other groups at Bond University in this new building. The admission criteria is very similar to what Grace shared with you. So age over 65, Gold Coast resident living at home, not residential aged care facility, a score greater than 1 on the frail scale, but also interested in other at-risk things. So those clients that you think might be socially isolated, you know, demonstrating poor self-care. They come into the GP practice and they look like they haven't had a shower in a week, or they're just losing their personal, sense of self-pride. Recent hospitalisation, well aware of the links between recent hospitalisation and hospital-acquired deconditioning and the impact on frail people, polypharmacy, multimorbidity, falls, nutrition, low socioeconomic and mood changes. So we will have assessments of mood and of cognition, and we've got a brain gym that's factored into the program. I won't read out the rest. The one that is important is that do need to be cognitively and physically able to provide informed consent, and physically able to participate in group activities and in an exercise program. And our referral form is very much like Grace's. I apologise, this is a bit jumpy tonight. Here we go. And that will be available on the website. We've made it similar so that it's easy for you to refer. And you'll just have to note we've just got a different letterhead with the Bond University logo on it. And we've got two key indicators, the Edmonton Frail Scale and the SF36 to assess quality of life. In addition to that, we've got a suite of other indicators that we will be collecting depending on the discipline. So in summary, OT, exercise science, physio, dietetics and nutrition, 12 weeks, twice a week. And that's it in a nutshell.
Thanks so much, Susan. All right then, so we'll just leave questions to the end. But next up we have Amy Tooley from Gold Coast Health, and she's going to be speaking about the Better Cardiac Care program and the Mungali Clinic. So I'll hand over to Amy.
Thank you very much. I'll just wait for Susan to unshare. Thank you. One moment. Okay, can everyone hear me and see the slides there okay?
Perfect, Amy.
Thank you. Good evening, everyone. My name is Amy Tooley and I am the clinical nurse consultant for the Better Cardiac Care program, which is a new service to Gold Coast Health, which I'm going to elaborate a little bit about this afternoon, and then we're going to talk about our Mungali program here. So both of these services are part of our chronic disease and post-acute programs team here at the Robina Health Precinct. Okay. So first of all, I just wanted to explain our new service that's just come into Gold Coast Health. The service started in October last year. It was a part of the national initiatives supported by the Australian Health Ministers Advisory Council as part of our government's commitment to closing the gap in life expectancy for Aboriginal and Torres Strait Islander people. The program actually started in Metro South at the PA Hospital in 2015 and has now received funding to expand across Queensland, which is amazing. So the program aims to reduce mortality and morbidity from chronic cardiac conditions by increasing access to services and better managing risk factors through education in the community and by coordination of care. So our multidisciplinary team for the Better Cardiac Care initiative consists of a clinical nurse consultant, an Indigenous health worker and a pharmacist. So this team provides access, support and knowledge to evidence-based, culturally safe cardiac care for our Indigenous clients. So we meet the clients initially at the acute phase of illness in the hospital setting, and then provide support through out of discharge and then into the community. So as part of this initiative, we actively link patients to community supports while they're an inpatient. So lots of our cohort don't have GPs to follow up with within the community. So we will link into Aboriginal medical services and GPs in the client's local area and actually arrange follow-up with that person within 7 days of discharge. We also ensure that cardiology specialist follow-up is attended and arranged before it's definitely arranged before the client has left hospital, and then we make sure we facilitate them attending that appointment as well. So in the community, our team supports, navigates and coordinates cardiology care pathways for our patients, and we provide a link to specialist investigations in the community as well. So the main strategy for the Better Cardiac Care initiative, there's 5 pillars where the service was focused on. So number 1 is our primary preventative care. So this is extremely important, and we focus a lot on our early cardiovascular risk assessment for our cohort of patients. We are looking at a cohort a lot younger, experiencing cardiovascular disease with an onset of age in the early 30s and peak of disease at age 50 to 55. So education and management out in the community in a primary prevention setting is extremely important. Clinical disposition of disease. So we want timely diagnosis of heart disease and heart failure. So it's having those investigations done earlier in the community setting. And the acute episode. So we want to see those patients having that guideline-based therapy, going through to the cath lab and having the treatment that they need. Ongoing care, so we're optimising the health status and provision of ongoing preventative management. And we've got, we'll talk a little bit more about that as we go through the slides. And rheumatic heart disease is also something that we do see here on the Gold Coast as well. So we're wanting to strengthen the diagnosis, the notification and the follow-up of our rheumatic heart disease clients. So overall, the service and the 5 pillars, we're here to support people to prevent and manage their cardiovascular health. We want to reduce the gap in cardiovascular disease mortality, particularly in our clients under 50 years old. And we want to reduce the rate of progression to moderate or severe rheumatic heart disease. So from a health system perspective, it's known that lots of Aboriginal people feel uncomfortable, fearful or powerless when they try to use the healthcare system, and often avoid going to hospital or even to the GP when they are very unwell. So that's come out of our Better Cardiac Care measures for Aboriginal and Torres Strait Islander people, 5th National Report. And we see that all the time in our failure to attend rates for follow-up appointments and GP and specialist outpatient appointments. We see that there's a disconnection between the community and the acute setting. And we see that also in our high discharge against medical advice rates as well. So I guess essentially these are symptoms of a healthcare system and service that don't support the patient-centered care, which we want to change. So our model of care is very culturally and clinically focused. So our Aboriginal health worker is at the key of our model of care, and all of our client interactions are culturally safe with the support of our healthcare worker. We also have our, obviously, pharmacist and nurse consultant, and we meet the clients in that acute phase of illness and build the trust relationship to then extend out into the community setting as well. So we also support our...
Too loud.
Sorry?
Sorry.
We also support patients who discharge against medical advice. So we have a plan of approach to that as well, because that is unfortunately something that we see 5 times the rate of non-Indigenous patients. So we have a plan in place for those patients who do discharge against medical advice. Although since the service has been started in October, we've only had 1 case, which I'm proud to report. We look at improving health literacy for our clients as well. So we've developed many resources. One of them, which we have a lot of positive feedback from our patients, is our My Heart Wellness Plan. So this booklet is written in the patient's words in the inpatient setting. Patients describe exactly what's happened to them, what's brought them to hospital, what we did for them, whether it be they came in with a heart attack, we've opened up that artery with a stent now, and then what is the ongoing care. Their GP, new GP details will be in there with their follow-up appointments, all of our Better Cardiac Care contact details, and then when they go home into the community, we get them in for an assessment within 2 weeks of discharge to follow up. We also send our GPs, because we're arranging these discharge appointments within 7 days of discharge, And as we know, unfortunately, our electronic discharge summaries from the hospital don't always make it on time for the person's appointment. So we also, from the Better Cardiac Care point of view, will send you as the GP a briefing document. So this just goes through the situation of that admission. So why they came to hospital, their medical background, because a lot of times these clients may be new to you. So we want to provide you with a history there. The assessments that we, in investigations that we've done in hospital, and we'll also attach the reports. So your echocardiogram, your angiogram reports, and your medication profile will be attached to this. And then the hospital's recommendation from the treating team. So this document doesn't replace the electronic discharge summary. It's just a briefing document so that when clients do attend those appointments, if you haven't received communication from the hospital, you have the information that you need for that appointment. We have lots of brochures for all of our services and patient resources. So please reach out if you would like us to provide any for your practices. Lots of our clients love these resources. They explain how to get in touch with us very easily and what each service does. So more than happy to do that. And I just wanted to show the results from the PA Hospital from the founding site who started this amazing initiative in 2015. They were able to show significant reductions in failure to attend and outpatient appointments, an increase in GP uptake and follow-up, which is very important, as we know, and there's a lot of other stats there, but significant reduction in repeat AMI within 90 days of discharge. So that's showing us that medication compliance as well, which is great. Okay, so now I want to focus on another program that we offer for our Aboriginal and Torres Strait Islander community, run here out of our chronic disease and post-acute programs team at Robina Health Precinct. It's our Mungali program. Mungali is the Yugambeh word for cotton tree, which traditionally was a source of making spears and strings and boomerangs for the Yugambeh people. So we aim to be a source like the cotton tree to provide the community with knowledge and resource. So that's why we chose the word Mungali. As you can see here, the Mungali offers a holistic approach to managing chronic disease conditions. It's run by a multidisciplinary team here out of Robina Health Precinct. We are able to attend home visits, community Aboriginal medical centres, GP appointments. We also offer education out in the community at Aboriginal and Torres Strait Islander run events, and that's a huge part of our promotion and our prevention strategies. So we focus on recognising signs and symptoms and changes in health and building that confidence to work with health professionals. All of our programs are run with the cultural support of our Indigenous health workers and linking clients into their connected community, which is extremely important for ongoing continuation of care. We develop health cairns that are specific for our client-centred goals. So it's all about what the client would like to get out of this program moving forward. And then we facilitate the integration team to achieve that goal for the client. Our team here, as part of the Mungali program, we have our Indigenous health workers. And like I say, they are the centre of this program and provide our culturally safe space for all of our clients. We also have clinical nurses. So once a referral has come through to the service, the clinical nurse is the first point of call with the health worker to identify those client-specific goals and put a plan in place, and then bring in other members of the MDT team. Physiotherapists are a huge part. So our physiotherapist runs a gym once a week. She also has one-on-one assessments when all clients are referred to find out the specifics of what that client needs. In that assessment, she might attend to a 6-minute walk test. She might do sit to stands, grip strength. It'll depend really on each individual client. She'll then refer them to our weekly gym class, which is run on a Friday for our Aboriginal and Torres Strait Islander clients in a culturally safe space with our physiotherapy and clinical nurses there to support. She'll also organise home exercise programs as well. So I will talk a little bit more about our Yarn and Walk program, which is coming soon, which is an outdoor exercise activity as well. We have our pharmacist as part of the Mungali and Better Cardiac Care team to consult medication reviews, which is extremely important, and medication education for all of our clients. She also runs a smoking cessation program, which has been very popular and successful. We have a dietitian as part of the team, and our Mungali dietitian offers one-on-one appointments, home visits. She does cooking classes, group education, and nutrition focused meal planning individual for each client. And we have our nurse navigator, so helping to support our clients through the health system, especially our elderly cohort, because as we know, over appointments can be very confronting. So our nurse navigator makes that very streamlined for our clients, so they're not overwhelmed by so many appointments. Additionally to our MDT in the Mungali program, we can also refer to our chronic disease and post-acute program MDT. So that includes our diabetic nurse educators here at Robina Health Precinct, our podiatrists, occupational therapists, psychology, social workers, exercise physiologists, and speech pathology. So I think that's really important to remember as well. And I just wanted to skip ahead to show you that. These are the programs that we offer. So we do education programs frequently. So we have our Elders Strong and Deadly Wellness program, which is run 4 to 5 times a year. It offers a 5-week community-based program. We cover cultural activities, healthy eating, chronic disease and medication education, and physical activities for our clients. This is offered out at Kelwyn Wellness Centre at Benogan. So it's a beautiful space for our clients to come. We sit out on the veranda, we have a yarning circle, and we talk about chronic disease and physical activity. So we actually started our program next cohort this afternoon, which is very successful. We also run a Deadly Tracks education half-day session, and this is where our thank you PHN funding has come through for the Yarn and Walk program, which will be offered to our clients every week in a supervised physiotherapist-led exercise session, followed by a yarning circle out at Cheltenham Oval in the sunshine under the trees. So that'll be lovely for our clients as well as the gym on the Friday. They'll now have this option on a Monday, very supported by all of our multidisciplinary team. I would like to now show you a video and hearing from our Mungali service from our team. One moment, please. Here we go.
Jingari Jimbalang. Hello friends in the local Yugambeh language. I am Jodie Gerard, the Advanced Aboriginal and Torres Strait Islander Chronic Disease Health Worker. The Mungali service supports Aboriginal and Torres Strait Islander people manage their chronic disease. As a member of the team, I can support you to access specialist nursing and allied health professions whilst working closely with your GP. I work alongside clinical nurses, physiotherapists and dietitians. The Mungali service offers a range of programs. We have the Strong and Deadly Wellness program, a community-based client-focused program to inspire you to be the healthiest version of you. This 5-week program includes education, cultural and physical activities. The Mungali Wellness Clinic will listen to your story, develop a plan and focus on the health issues that are most important to you. We have the Mungali exercise class, weekly classes with an individual exercise program based on your needs. We also have a Deadly Track education program, which is a half-day chronic disease education session.
I've been attending the Mungali Clinic now for many, many years. It's a wonderful service. I've made many, many friends. The staff are wonderful. I keep telling all my friends to come, and I've met many good friends through the program. We learn all about our health and wellbeing, and I encourage everyone to come along because it's a wonderful program.
If you'd like more information on how to refer into a Mungali service, please contact the number on the screen.
Okay. All right, so moving along, I also wanted to discuss our other chronic disease and post-acute programs that might be applicable to your clients. The Falls and Balance Clinic is run here out of Robina Health Precinct, and it's a multidisciplinary outpatient diagnostic service, which is targeted to clients who are falling or at risk of falls. The MDT associated with this clinic, which is run here out of Robina Health Precinct, are our geriatricians, rehabilitation specialists, clinical nurse consultant, pharmacists, and physiotherapists. So I thought that was important to mention tonight, considering the topic that we're discussing. This clinic actually does require a GP referral, so Allied Health can't refer straight in. However, if we identify any clients through our programs of the Mungali program or Better Cardiac Care who may benefit from the clinic, we will write to you as the GP and suggest potentially you might look at referring in. We also have a cognitive disorder clinic service that's run here out of Robina Health Precinct. Eligibility for this service is for people over 45 years who are experiencing cognitive problems, characterised by progressive cognitive decline and or memory impairment. So it's not in relation to personality disorders or illicit drug use or pre-existing brain injury. So there's a few eligibility criteria for the service, but it's once again a diagnostic program which has a comprehensive multidisciplinary team approach with a specialist consultant, clinical nurse, neuropsychologist, and a speech pathologist. So very run twice a week here at Robina Health Precinct. Once again, any information you would like for your practices on any of our programs, please reach out. And our referrals normally through Refer. If you want any information on any of the programs I've discussed, please go to Refer Your Patient website. And our preferred method of referrals for all of our chronic disease and post-acute programs is via our Smart Referral workflow solution. But if that's not a software that you have access to, you can always send referrals through to our intake hub on the fax provided. And any questions at all of any of the programs, please call our 1300 number and we can provide any information. So moving forward, thank you so much for your time this evening and listening to our new services for our Aboriginal and Torres Strait Islander clients, Better Cardiac Care and Mungali. Please think of these services when you are seeing your clients in the community. Any questions, please reach out. Thank you.
Great. Thank you very much, Amy. That's fantastic. Got a great array of services there. Look, it's been fantastic listening to all of the referral options that are now available and the Gold Coast Primary Health Network has invested in. So we'd like to take some questions from the audience tonight, either to Joyce, to Susan, or to Amy. So while, and you might as well put a question in the chat, or if you want to just put your hand up and then unmute, then we'll take a question live as well. But Joyce, one I'd like to put to you first up. You mentioned referrals from a GP, but what about the hardworking primary care nurses that are seeing many of our older patients? Tell me how they can make a referral to you.
Yeah, great asking that, Chris. Absolutely. The nurses can be part of the referral process because they're the ones that will be seeing the patients for some of their care plan assessments, the health assessments. So I suppose, you know, to help the GPs out, they're right at the forefront of that. So they would be very, you know, important to this pathway of identification. So that form can be completed by a GP practice nurse, and then, you know, the doctor can be highlighted of the program, reminded of it, and the doctor can also basically complete it or co-complete it with the nurse and then send it in from there. Yeah. Right. Okay. And the other question I had for you was about the electronic signature, or, you know, you've got an electronic form using medical objects. Does that really need a physical signature? Yeah, no, when I say sign off by the doctor, it's literally approved by the doctor. That's probably the better word. Yeah, absolutely. It's all, as I said, the RTF form will be converted in the software. So just auto-populate your details, just so we know who, as long as we know who the collaborating referrers are, where that's all we need. Great. I've got a question here for all of you. So what service is available to patients in the southern Gold Coast around the Coolangatta area, which I noticed that Robina was mentioned by a number of you, but what about sort of in the Coolangatta area? Yeah, we can access, I'll answer before the others quickly, because we can access the Coolangatta Community Centre, which we used to, and it depends on the demand. So we're kind of going to go where the people are. We've also got the mobile service as well. So in the early days when we started the pain program, it was all across, it was Southport, Robina and Coolangatta. Some of you guys may remember that from the days. Now, progressively, we've actually just kind of come into the Robina area because patients actually told us that it was more convenient, even the Southerners. Now, I understand this is a different cohort of patients, so I think feel free to refer in and we can certainly look at the demand. And there's home based as well for those who need it for their, risk assess high risk. We'll certainly start in their homes.
Thank you, Joyce. Amy, what about your servicing of the Coolangatta area?
So we are a mobile service as well, so we can attend obviously home visits with our MDT. What we do is if anyone's in northern New South Wales, so over the border, we refer to services that New South Wales Health provide our clients. So there's a lot of Aboriginal medical services in northern Tweed area, and we also refer our cardiac patients to the Tweed Heads cardiac rehabilitation programs that they offer, and also Lismore cardiac rehabilitation. But it's an excellent point to bring up, because in terms of our walk and yarn exercise and physical activity and education programs, and our education programs that we run, such as Strong and Deadly Tracks, I think it's a very valid point that we should be looking at potentially moving some of those programs to that end of the coast to service more people down there. So thank you for raising that.
And what about Susan? What about your ability to service the Coolangatta region?
Absolutely. So we're a new program. So initially we're going to focus our efforts in Southport and Robina, and part of that was based on the demographics. But once we get the model right, we're considering providing some outreach programs depending on need. The benefit with where we are at Robina, though, is we're right off the freeway, and the Bond Institute of Sport's right opposite the Robina train station, so it's well served by public transport.
Well, I think that's a pretty key point, being accessible. And I guess like many new services that are at an early stage of development, you'll await the demand. And as we pointed out earlier, that there are various parts of the coast that have a lot more older people than other areas. But, again, it's pretty much across the board, isn't it, on the coast? So let's
the other issue is the demarcation of the Gold Coast Primary Health Network and the border.
Of course, yes. So funding doesn't cross boundaries very easily, does it? But Amy, thank you for your ability to cross a boundary. So yes, that is often a frustration to us as GPs when it comes to referral criteria. What about any of the GPs or the nurses that are on the call? What about some other questions about any specific patient groups or about recognition of frailty that Joyce, Amy and Susan maybe will be able to respond? Hello, Dr. Kish, good to see you. Any questions you'd like to put to the panel tonight about your patients? If you'd like to unmute. You just need to unmute.
Sorry, I was on mute. Yeah, thank you everyone for all your presentations. Yeah, I don't have any specific questions. Thank you for bringing this to our practices, and looks like our patients are really getting benefited, particularly the tools being implemented in over 75 health assessments, which are now linked to driving medicals. So in our practice, as a policy, if you haven't done the health assessment, we won't give you the driving clearance. And the health assessment, we are following through all of these unless it's mandatory. These things are not happening. And so everything is going great. I don't have any specific questions. Seems like it's more of a refresher. Thank you.
Good. Sounds like you've got plenty of people that you'll be referring tomorrow.
Oh, yeah. I mean, our practice, relatively, we have quite a few elderly patients, I suppose.
That's good. Thank you, Dr. Kish.
Thank you.
Hello, Jane. Good to see you.
Yeah, hi. Thank you. It's been a really interesting evening. Did I hear you right saying you only need a frail scale score of 1 to be eligible? Because
For our service, yes.
everyone is tired. So that means my whole patient population qualify. Is that really all you need, a score of 1?
So Jane, the reason that if you go back to the Morley Frail scale that we talked about earlier, where essentially the evidence of our, healthy aging is if we can start earlier on that trajectory, that then you'll make the biggest inroads. I think that's one of the really important areas here. So there are a lot of people who are at high risk of developing frailty. And fatigue is often one of the early signs that you're going to start doing less. And as you start doing less, you become more sedentary, and the sarcopenia ball starts rolling down the hill much more quickly. So it's like the thin end of the wedge. We can pick that up early. So pre-frail is 1 and 2, and frail is 3 or more. So this pre-frail group is actually under-recognized in our practices. And very interestingly, there are a lot of 40 to 49-year-olds. 30% of that group are actually in the pre-frail area right now, looking at some studies. So I've actually been working with some researchers in Adelaide on this. So it's especially as more of our cohort have type 2 diabetes and have BMIs over 30, this is slowing down their activity levels, and they're in that pre-frail group.
So you've got the facilities to cope with our referrals?
Well,
so Jane, that's what we're testing. Just in terms of your frail score of 1, though, we've got at risk of frailty. So obviously a score never replaces good clinical judgment.
Okay, thank you.
If you've got somebody who, is socially isolated, they might have lost a partner, you notice poor self-care, recent hospitalisation, there are other things in combination with that.
Sure.
I don't have to do a falls risk assessment to know somebody's at risk of falls. I just look at them and say they look a bit dodgy on their feet.
I think GPs would be the same. Yeah.
Yes. So I wouldn't get too hung up on the score, but I looked at that and I qualify.
Okay. Thank you. I will mute myself again.
No worries. Thank you, Jane. I guess the main thing too is, without opening the floodgates, it's really the focus is on people over 65, and in the First Nations group over 55.
Can I just also clarify and just, of course, these services are new, and sometimes trying to sit there referring and going, who's who in the zoo and who do I go to? Look, I think because we're providers funded by the PHN on the GC, we will be communicating and regularly, catching up, I hope. So that's a plan anyway. So I think if you feel the patient's at risk, whether clinically observations or through the tools, send it into one of us, because at least what we'll do is, if it's not appropriate for any one of us, we'll share it amongst each other. We've talked about that, we've agreed about that. So I think that's really important to not overthink it so that we can early intervene. And there may be some overlaps, which are totally fine. And I think in these early days, there would be the option of potentially, people having a higher priority, let's say for medication review, and that may say come into us, but then after a while when they're done and we feel like, look, it's actually better to refer into, Susan's services, then we can sort of also do that, just depending on the priority. But I think sometimes I appreciate, and this is also from some of the feedback from having done the persistent pain services, I think I appreciate sometimes it's a bit overwhelming for the nurse or the practitioner out there, the GP, to go, oh, who now? You've suddenly got this great menu and you're wondering who, and then it mightn't refer to happen because you're thinking about it. So I think just get it through, and then we'll certainly be sorting it out and communicating back to you. If it's, we weren't the right one, you'll be aware, go to this one instead, and so on and so forth. Yeah.
Well, I think what all three of our service providers tonight are really showing that for that lovely word Susan used, lifestyle redesign, it's actually a team game. And one of the really important thing is going back to, we've got to ask our patients what really matters to them. What's the number one thing on their list that they want to achieve? Now, and that's actually a team sport, that with the patient at the center going, right, these are the things that I really want to achieve. And often it requires a team to actually deliver on that, to help support them through that redesign of their lifestyle. So I think what we've actually heard tonight is just some fantastic offerings of exactly that, where it's not like just you're referring to one person. It's this lovely team approach so that our patients will actually get the best for themselves, as the lovely video, that the best version of themselves can only come through supports that are quite sort of broad and integrated. So Susan, anything else you'd like to add at this point that reflects from the discussion?
No, I think you're right, because we're time limited, but our intention is when we do our assessments, is then identifying a management pathway post-program, and then with opportunities for events. So while we're promoting it as a group program, what that is an entry point to other individualised assessments. So Dr. Kish, I think it was, talked about driving. We are looking at running a driving assessment clinic, because that's a skill set that occupational therapists do. And it's something that when we talk about frailty, we talk about sedentary behaviour. It's that very symbolic thing that people get quite upset about, is when they lose their licence. And having those conversations. So it's really about holistic healthcare. I know I'm talking to GPs here, but trying to demedicalise it and trying to put it in a different framework, that this is about you being your best version of yourself, and living as long as you can and staying out of nursing homes. And that's ultimately what the government wants and what the PHN wants.
Yeah.
And being treated humanely and compassionately, which Joyce started off. I think we're all very compassionate and passionate about what we do. And we want these people to feel welcome, because when you look at that video you had, Chris, of Mrs. Andrews, you know, I could pick so many holes in how that lady's care was managed.
Yeah. Exactly. And I think that's the thing. If we then go, right, all of us that are on the call tonight that are over 40, that's potentially a trajectory for at least 20% of us. So we've got to start thinking at our earlier age that what can we personally do? And if we actually need some support, then what you're offering is a way forward. You know, this is a really rare opportunity to have such an integrated approach to better care. As you mentioned, with many of the medical models, that all of our training as GPs is all about, you know, often acute illness, single disease. Now we're looking at multi-morbidity. Add that to this experience of aging, where we've got the physiological issues that change, as well as the functional issues. So there's this great clash of medical issues, physiological, as well as the function. And so that needs a team to sort this out. And it's as we've already said, it's not more medications. It's actually probably less medications and more focus on what can we do to help improve function.
Yeah, and it's about changing perceptions. I mean, a lot of, you know, I know my generation, you know, you think you're going to the gym, that you're going to walk out looking like Arnie Schwarzenegger, you know, and it's about pumping iron. So it's changing attitudes, that it's not like that. The activity and exercise takes many forms, and it's a profession on its own with a very, very solid scientific base. So it's integrating that, you know, with the pharmacology, with the mental health and well-being, with the physical abilities, and you know, the GP is at the centre of that care. And if we can provide, you know, some additional information that helps you with your ongoing management of them through, particularly because we're using students. Students have all the time in the world to do a very thorough, you know, assessment and interview. And we've found through some of our pilot studies that we've done, that the older people respond very favourably to that, because they see the students as their grandchildren and they want to help them to learn. So, you know, that's another benefit in terms of moving forwards, but training our students that, you know, GPs are our friends. How do we work with them? And when you graduate, you know, these are some services and strategies that you can use.
You know, I actually really enjoyed your thought on the developing workforce, because as we know that unfortunately our lovely hospitals are often the main area where universities train students. So the opportunity to actually have people from the community where the majority of people live and actually function, for our students to actually access and help support people in the community is just wonderful. So yeah, clearly lots of bonuses by all three programs being introduced. Now, Joyce, just before we finish, because I'm looking at time, it's around about finish up time, but I've got one last question for you, which I think some of the GPs and nurses might have thought about while you were presenting. You said, look, a mental health care plan may be required to access a psychologist in your team. Now, knowing that there's often a long wait for us to refer individually to psychology services anywhere actually around Australia currently. So is this actually an opportunity to say, right, if my older person is screening frail, then you actually have some access that it won't be a 6-month wait for that psychologist?
That's correct. Absolutely. Yeah. Yeah. Same with our pain services as well. That's the same thing. We've collaborated with, highlighted, collaborated, you know, our stakeholders. Our teams are interested in working in this space. Yeah, that is correct. And also, in addition to that, many of them, and I also understand there's a cost barrier, right, as well, because there is gap fees as well. So not to say that all of them will be bulk bills, because we do, or no gap fee, I mean. However, within their kind of working in this partnership, that is kept really, really minimal. And most of them really, you know, try very hard to exempt that as well, because we've got funding that we can also try to co-help with that for sure. So that's on a case by case, but absolutely, yeah, that is correct. Can I just also add that, you know, hopefully with regards to what you guys were saying with the workforce, because we're using developed workforce and people interested in that space in primary care already, so, you know, with different seniorities, I think it'd be lovely potentially to see as students, and I don't know what level students you've got, Susan, but I imagine they're, you know, kind of getting into their senior years now. They be really good to kind of, you know, also partner them out to the workforce that is going to be looking for workforce and well-trained workforce well exposed to things like this, right? So there could be that crossover, because these kids are, well, hardly kids, are they? These students are going to be looking for work. And I think there's nothing better than workforce that we've already got working in that space. They're always looking for who's had exposure, who's trained. So it could very well be a nice health ecosystem that's beginning.
Excellent, Joyce. Okay, well, maybe we'll better hand back to Katie and wrap up now. Katie, any last final words from the Primary Health Network team? I see that the Primary Health Network website will have the referral templates up fairly soon.
Yes, that's right. Thank you so much to everyone who's come along today, and deep appreciation to our speakers, as I said earlier in the night, for giving up their time to come along. I think it's been really interesting and helpful even for me listening in on the different services and the work that you're all doing. So in the next coming days, we'll have the referral templates or information on referring into each of the services on our PHN website, and we'll send out information to general practice to provide those links as well. So watch this space, and as you have all attended tonight, you'll get an email too that links through to that referral information. I think that's it. If there is anything else that you would like to follow up with PHN, please always reach out to our practice support email or phone, and we're more than happy to help. But other than that, thanks so much, and we'll let everyone get on and enjoy the rest of their evening.
Thank you all very much. Good night.
Thank you.
Thank you for the opportunity. Bye.
Bye.